Hello, my name is Jenny Jen. I'm a second-year rheumatology fellow at USC, at University of Southern California. And now I have an interesting case report to share with you all for RWCS. So we have a 22-year-old man with no significant past medical history. He came in with about 10 weeks of a very strange polyarticular symptom when he didn't have any significant past medical history prior. So what happened was, because of this very severe joint pain, as anyone would, he took ibuprofen but didn't really work. Then he went to other doctors, got a middle dose pack, and that did help, but only temporarily. So then, all his arthritis had improved. He also developed a very strange looking rash. Initially he thought they were pimples, but then they started spreading all over his chest, including his face and his arms, and they were not resolving in any way with the middle dose pack. So then he came to our emergency department. We were consulted because there was significant concern for septic arthritis from the emergency department standpoint as a young male. However, in conjunction with that arthritis, he also had a very strange appearing rash, and this was definitely something that we don't typically see in rheumatology. So we consulted dermatology to also take a look at this case. Fortunately, he was able to receive not only a joint tap of his left knee, but also a skin biopsy. And then when the results came back, we came with a very strange diagnosis called Blastic, Plasmacytoid Dendritic cell Neoplasm. So just to go back to the case a little bit more, on exam, he didn't have any fevers, but he was tachycardic to 106. And he was very fatigued appearing as well. There was no lymphadenopathy that was palpable, but he did have extreme pain out of proportion in multiple joints, his wrists, his knees, ankles, some of the fingers as well. And he was unable to stand because he had so much pain going on his heels. On the labs, what was notable, although his CBC, interestingly, was completely negative, we checked for the typical concerns from a rheumatology standpoint, checked for ANA, ANCA, we checked rheum factor, CCP, so CK, all of which came back negative. ACE level was also negative. So then we looked also for infectious causes, but all of which panned as negative too. Cultures were negative from the synovial fluid, and also from multiple serologic tests that we did, looking for like HIV, hepatitis B, C, and CMV as well, none of which came back positive. So then this is a skin exam right here. As you can see, he has these non-tender, very nodular, hyperpigmented lesions everywhere. And one of the largest lesions that we saw was actually in the left lower back. Once he came with diagnosis of the Blastic Plasmacytoid Dendritic cell Neoplasm, which I'll call BPDCN from now because it's such a long name, he received treatment for chemotherapy with ALL treatment. And 4 days after receiving vincristine, daunorubicin, and prednisone 60 milligrams, his arthritis completely resolved. And in terms of the skin exam, so this is a picture of 2 weeks after starting ALL chemo induction therapy. And as you can see, the lesion is much smaller and flatter as well. He didn't have any development of new lesions going on. He also had an X-ray done, which showed a radial lesion going on in his right wrist. And this is also PET CT whole body. And as you can see, there's multiple lesions lighting up with metabolic activity in his skin, also in his patellar region, his wrists, also in the calcaneae. And so once he received therapy and subsequent PET CTs, these lesions all have decreased metabolic activity going on. So the way that he got diagnosed was he had several markers that were positive. So typically in BPDCN, this is coming from a plasmacytoid dendritic cell lineage. So the markers that are typically positive are CD123 as well as BDCA2, but there are also other markers that come up positive, such as CD4 or CD56. But this is a very aggressive neoplasm. It's very rare, affecting 0.04% out of 100,000 cases. And without proper treatment, these patients die within a year and a half for those younger than age 20, and 4 months for those patients who are over 60 years of age. But typically the way that it's treated is with chemotherapy followed by hematopoietic stem cell transplant therapy. And these patients, once their chemo is done, their arthritis completely resolves. So that is another characteristic of this condition. So BPDCN typically has not been well described to have arthritis in initial presentation. Typically affects the skin, bone marrow, lymph nodes, but this is a rare case already, also the very rare initial presentation. So when we have cases like this, one of the take-home points is very important to get all of your proper consultants involved because without a proper diagnosis and treatment, these patients can have a fatal outcome. So, yeah. Thank you.